morning, everybody. Wakey, wakey. It's time for Morning Glory. My name is MC Kalia, and I'll be your captain for the next 1 hour, 30 minutes. Let's have this conversation going. Good morning, everybody. Wakey, wakey. It's time for Morning Glory. My name is MC Kalia, and I'll be your captain for the next 1 hour, 30 minutes. Let's have this conversation going.
Topil Hospital, a brain and spine specialty hospital dedicated to providing extraordinary care through competent doctors and other medical personnel from premium institutes with knowledge on the latest and exceptional medical technologies. With a capacity of over 70 operational ward beds, over 30 specialists and consulting doctors, Topil Hospital is a modern level 5 facility equipped with 12 state-of-the-art ICU HDU beds and 2 modern HEPA-filtered theaters with laminar airflow. Our aim is to provide comprehensive quality services at an affordable cost to the community, which includes but not limited to neurosurgery, radiology and diagnostics, MRI, CT scan, X-ray, ultrasound, endoscopy, ECG, EEG, pediatric cardiology, physiotherapy, orthopedics and trauma, pharmacy, laboratory, theater, ICU and HDU, obstetrics and gynecology, general surgery, maternity, psychology, psychiatry, comprehensive wellness checkup, dialysis and urology, oncology, dental care, ENT surgery, nutrition and dietetics. For ease of movement and transfer of patients, the hospital has 2 modern critical care ambulances equipped with ICU facilities and available 24 hours. Topil Hospital is located in a serene environment away from noise and has a cafeteria with fresh, nutritious foods, not forgetting ample parking for all clients. Topil Hospital is NHIF accredited and accepts medical covers from a number of insurance companies. If you're looking for the best customer care and patient experience and to be attended within the minimum waiting time possible, reach us through the website www.topilhospital.com or call 0782 121214, or you can also call 0782 900090. You can also email us through info@topilhospital.com.
Good morning to you. It is indeed Wednesday, the 8th day of March 2023. My name is MC Kalia. This is the Morning Glory Show, and welcome to this particular broadcast. Now, happy International Women's Day. Actually, I saw some people started doing that yesterday, but then for those who are wondering when will Kalia do it, I was actually waiting for the right time. So to all the women out there, our mothers, sisters and wives, happy International Women's Day. We at the Morning Glory Show and by extension Dawi Africa Photography and Very Nice Media, I would love to wish women all the best, and I actually love the theme for this year, which is digital. And as I told, maybe I need to tell my guest here, who is actually Daktari, I have not mentioned about him to you, that the theme for this year is digital, but then the all part is actually in capital, so that means that it is then all. Like, and when you extend that, it goes on to say that it is innovation, technology and innovation for gender equity, which actually also prompts our topic today. We decided to talk about cervical cancer because it is what is eating up most of, I would say it is the second most prevalent cancer among women today in Kenya. And so we have Dr. Issa Moshey. He is a consultant gynecologist who will help us understand cervical cancer. But then before we go there, we're coming live from Dawi Afrique. Dawi Afrique is a photography stroke videography studio situated in Eldoret, Zion Mall, basement A. Now, if you're wondering why I'm really insisting on this, it's because I know that weddings are starting by 15th March, April. People will be wedding during the April holidays. And if you need nice memories of those events, then consider working with Dawi Afrique Photography. And also, iwapo ungependa kupiga luku, then the right place to go is D-Square School of Fashion Design. But then before you go to D-Square School of... okay, now, I'm doing this wrong. If you want to pick a look, go to D-Square Fashion House. But then if you want to learn how to pick a people look now, you need to learn how to do designs. Then you go to D-Square School of Fashion Design. The sweetness with learning from D-Square School of Fashion Design and Tailoring is that the fashion house is just adjacent to the fashion to the school. So that means that immediately you get out of class, then there is a possibility of you actually walking into the fashion house and learning from designers who've been there before. Daktari will still confirm this. Most of the hospitals usually has a school. Kando yake ndio ukitoka shule unakutana na wagonjwa directly. So it's the same situation with the D-Square School of Fashion Design. Without much ado, allow me to give a chance to Daktari to say hi to you and also maybe introduce today's topic. Karibu sana Daktari.
Good morning everyone. Happy International Women's Day to all the women out there who are tuned in today. You are the backbone of the world, of the globe. So it's only due us doing due diligence by acknowledging the importance that you serve to this world and wishing you a happy International Women's Day. Like our MC here, also boisterous, has pointed out to you, my name is Dr. Issa Moshey. I am a consultant obstetrician and gynecologist. Maybe just to introduce myself and give a bit of background about myself, I am a graduate, that is I did my undergraduate studies in Turkey at the Gazi University School of Medicine. And then I proceeded to do my master's, that is my specialization, at Moshey University School of Medicine. So I'm kind of feeling quite at my home ground because Eldoret is where I did my master's, where we are, live from. Today's topic is going to be a topic that is keeping in line with the fact that it's also International Women's Day, because cervical cancer is a menace that is really, really affecting our women, Kenya in particular, and the rest of the sub-Saharan countries. So it's quite in tune with keeping up with the theme of today being International Women's Day. So the topic today is going to be cervical cancer. For that particular reason, we shall go through the steps of the disease or the menace as we have identified it to be, and probably take in questions as we are done with the session. So back to you, Bana MC, to guide us through.
Okay.
Thank you very much.
Okay, thank you so much. I'm just staring at Daktari because he seems to actually walk away with my job at the end of the broadcast. Please, anyway, that's all right. Daktari, of course, the first question would be, what is cervical cancer?
So thank you very much, Bwana MC, for that good question. First and foremost, we might describe what cancer in general is, not just cervical cancer. So cancer basically, when you look at the normal body, how the body normally functions, is there is, particularly at the cellular level, the cells do undergo natural division, multiplication, and at the same time, there's also what is known as programmed cell death, so that you have a balance between the cells that are being formed, the new ones, and the cells that end up dying, so that you have this sort of rejuvenation process of the body, of the tissues that goes on indefinitely throughout life until someone dies. So the body itself, that is at the cellular level, has certain mechanisms that it controls this division and programmed cellular death to occur. So any insult of this, this natural mechanism that brings about an increased proliferation of cell deaths and reduced natural programmed cell death will bring about an uncontrolled growth of cells, which can eventually cause a cancerous growth, which at times might spread to other parts of the body using various channels such as the blood system, the blood itself, or rather the blood vessels or lymphatic vessels, or any other form of spread. So cancer in general is an uncontrolled cellular growth that might eventually bring about dysfunction of that particular organ where the cell growth is occurring. So when we bring it down to cervical cancer, it means the cervix in itself, as we know anatomically, that is, it's the lower portion of the uterus. The uterus being the, how we will refer to it in Kiswahili as nyumba ya mtoto. So the lower portion of it, there is almost like a door or an entrance to that uterus is through what is known as the cervix. So if there is uncontrolled cellular growth of this particular area, and in one particular area, so to speak, if the cellular growth is, uncontrolled, especially due to certain insults that we do have of that particular area, which we should discuss later, then you end up forming cervical cancer. And this cancer is not just something that is locally, contained in that particular area. It might end up, spreading to, the local neighbors of that particular area, that is the uterus. You can go all the way to the bladder at the front. It can go all the way to the, the rectum at the back. So these are some of the local areas where you can find the cervical cancer in advanced stages spreading to those particular areas, and it can go to even distant areas which are not even close to the uterus or the cervix, including the liver, including the bones, including the lungs, including the brain, even in worst case scenarios. So basically this is just a brief description of what cervical cancer is.
Okay, thank you so much for that, Daktari. And of course, we've already mentioned that it is a menace because it is actually, as we said, second most prevalent type of cancer. And actually, it comes to the top when we go to ages, I think, 14 to around 40 something. Let's talk about the statistics and the prevalence, Doc. How much prevalent is it in Kenya? What do the numbers look like?
Thank you for that good question. So we want to put it at the global perspective first before we move to the Kenyan context. Globally, in as much as we are talking about it being mostly our problem, that is African nations or lower middle income country, a lower middle income and middle income country issue, it's also something that also affects the globe at large. So globally speaking, it's when you look at all the cancers in men and women, cervical cancer is the 7th most seen cancer. And when it comes to women, it's globally speaking, it's the 4th most seen cancer. For example, if we are to look at the year 2020, where the most recent statistic is from, the year 2020, we had, globally speaking, roughly around 342,000 cases of cervical cancer in women. So you can just imagine, or rather 604,000 global cases. And from these global cases, we have almost 342,000 of women in the whole, world dying from cervical cancer. So it's not just the most commonly seen cancer in both men and women, that is, if they are collectively put together, but it's also amongst the leading causes of death when it comes to cancers of all natures. When we look at our local data, that is our local statistics in the country, that is Kenya, cervical cancer is again amongst the leading cancers. When we look at both men and women, it's actually the second, coming only second to breast cancer. As you can see, both the first and second most commonly seen cancers in the country are cancers that affect women predominantly, particularly cervical and breast cancer. So it's the second most seen cancer in the country. When it comes to cancer-related deaths in the country, it's the leading cause, unfortunately. So it even comes before lung cancer, it comes before breast cancer. So when you look at the year 2020, where we have the most recent statistics and data, we know that the new cases of cervical cancer in the country, that is Kenya, were roughly 5,200 in 1 year alone. From these ones, the deaths related to cervical cancer, again, that was the leading cause of cancer deaths in the country when it comes to both men and women. We had almost 3,000 of our women dying, 3,200 to be precise. And the trend has actually been increasing throughout time. When we look at 2012, the number of cervical cancer patients in the country, the newly diagnosed, that is, of that particular year, 2012, was, almost 3,000, and this number almost doubled in 2020. The number of deaths related to cervical cancer in 2012 was almost 2,000, and right now we're dealing with almost 3,200 women dying from cervical cancer. So you can see the number has almost been doubling over time, and which is why we really need to come up with programs or initiatives to kind of try to curb this menace of a disease that is claiming the lives of our women. So that's the statistics of the disease.
And of course, after looking at the statistics, then and you realize they actually always double. And also, while I was doing the research for this particular show, I also realized that as you categorize cancer, most of the time you'd also look at the issue of age, which also now takes me to the next question. Who is likely to actually contact cervical cancer?
Thank you once again for that question. So we're looking at the data that we have based on studies that have been done around the topic that is cervical cancer. We know that it's a disease that affects mostly women who are roughly around from 35 years to 49 years of age. Mostly women who are still young in their reproductive age groups are the ones who normally come to us with this disease. However, this is not to say that we've not encountered women who are young as the teenagers, 16, 17, 18-year-old young girls who've been diagnosed with cervical cancer. So mostly it's a disease that affects, women in their 30s, mid-30s, that is from 35-year-olds to 49-year-olds. That's the peak age group that will have most women with cervical cancers coming to us. However, it's not very unusual for us to discover even younger girls or even women who are older than this age group being detected to have cervical cancers. There are certain risk factors that come with it that is and one of them is the age, so that the older you are, you're more likely to be diagnosed with cervical cancer, as opposed to a young girl who's, say, for example, 12 years, 13-year-old. We cannot absolutely say that they cannot get it, but it's quite rare in those particular age groups. So that's the age group that is we are mostly talking about. And if we can move on to, the risk factors. And
of course, that would be my next question. What are the other risk factors apart from age?
Like you said, I'm trying to steal your job, so I asked myself a question. So the risk factors for cervical cancer, as we know them, and as has been established through various studies that have been done around the topic, include, number one, lack of screening of the disease. It's one of the most attributable factors for this, condition, or rather this disease. So for women who do not go for screening, they're at a higher risk of, being diagnosed with cervical cancer. And this can actually be compared in countries or populations where they have a culture of doing cervical cancer screening. Their rates of cervical cancers are quite low compared to countries where we are yet to pick up on that, culture of going for routine screening for cervical cancer. The other risk factors that are common, maybe I failed to describe the cause for cervical cancer when I was describing the disease in your initial question. But the most common cause of cervical cancer is this virus that I'm quite sure most of us have heard of, or our viewers have heard of, is the HPV virus, that is the human papilloma virus. The human papilloma virus is a virus that is, cervical cancers are attributed, more than 90% of the cervical cancer cases are actually attributed to this virus, that is the human papilloma virus. So the human papilloma virus is a virus that is mostly acquired sexually. So basically it's a sexually transmitted disease. Same way we will talk of HIV, we will talk of gonorrhea and chlamydia. The human papilloma virus is a virus that is acquired sexually. And 90 to 95% of cervical cancer cases are actually attributable to this virus, which is acquired sexually. So who else is at a risk of getting cervical cancer? Of course, someone who's sexually active, someone who's having multiple sexual partners, someone who's engaging in unprotected sexual intercourse, So these are some of the risky sexual behaviors that might predispose or make someone prone or rather have a higher risk of getting cervical cancer. Like I said, HPV is the leading cause of cervical cancer, or rather the agent that we blame the most for the cervical cancer. Fortunately to speak, all or rather most of women who are been sexually active even once in their life have a risk of getting this disease. And when we look at it, by the time someone has been sexually active, 86% of these women who've been sexually active by the age of 50s would have already been exposed to the HPV virus. So this is almost to say that majority of women who've been sexually active in their life will eventually get the human papilloma virus that is responsible for cervical cancer. Now, the good news is, in as much as these women are exposed to this virus, majority of them will end up clearing this virus from their body. That is 90% of women who would have acquired this virus in their lifetimes will eventually, through their natural immune system, will actually fight it off and kind of clear it off from the system. It's the women who actually are not able of, fighting off this virus, and it keeps on getting, infecting their cervixes and causing those changes that bring about cervical cancer, particularly women who are not immune, their immune system is not working well. For example, women who have HIV, women who have some form of immune suppression of some sort, including women who, say, for example, those who've undergone organ transplantation, we normally give them drugs that normally suppresses their immune systems. There are certain autoimmune diseases that are known to also, being treated with drugs that brings down the immune system of these women. So these are the women who will be prone to not necessarily clearing up this HPV virus, which will mean that they are more likely to get, cervical cancer in the long run. So like I said, if you have an immune system that is functioning and good enough, most of the times, in as much as you might have been exposed to the HPV virus that causes the cervical cancer, 90% of women who are exposed to this one will clear it up. It's the 10% that has persistence of this virus, particularly at the cervical area where the cervix, the cancer will start from. These are the ones who are at a risk of, getting cervical cancer in the long run. So those are some of the few risk factors. Of course, we have others that have kind of been attributed to most other cancers, not just cervical cancers, including things that like obesity, smoking. Cigarette smoking was also one of the factors that has actually been blamed to be a risk factor for most of the cancers. So the most common, lack of screening for women, HPV virus, risky sexual behaviors that exposes women to this HPV virus, including multiple partners, you're not using protection from getting that virus. That includes, the usual way we normally advocate for both men and women to use. And of course, we have early sexual debut as another risk factor for those who start having sex, earlier on in their life, because the HPV virus, it takes a while before it forms cervical cancer. From studies, we know that it might take roughly between 15 to 20 years from the time someone has been exposed to the virus to the time someone is actually diagnosed with cancer. So it takes a long period of time. It's not just like something you get immediately and you start showing signs. However, the disease, that is the cancer invasive stage of the disease, might come a bit earlier for women who have not been, they do not have an immunity that is functioning well, which brings me back to the examples I've given. For example, women with HIV might even start showing signs, or rather might get invasive disease as early as 5 to 10 years after exposure to the virus, and this is because their immunity is not functioning the way it's supposed to be functioning. So these are some of the few risk factors of the cancer.
Of course, thank you so much for that, Dr. With us in studio is the Dr. Issa S. Moshey. He's a consultant, obs gyna, and with us today is helping us understand cervical cancer. Of course, it is in line with the International Women's Day, but then you realize that also January has almost 1 month talking about awareness for cervical cancer, and you realize why when you listen to him to give us the statistics. Actually, you realize that in Kenya, to be specific, the top 2 cancers that are seen by doctors mostly affect women. The leading causes of death through cancer is both breast and cervical cancer. Both affect the women, and that actually informs our conversation this morning. If you're just joining us, welcome to the Morning Glory Show. Of course, if you're joining us for the first time ever, then continue. Remember to click the notification button so that next time we go live, you are able to see this particular broadcast. Keep the questions coming. Of course, I'll be sampling them at the end of this particular broadcast. And also just to remind you is that we are coming live from Dawi Afrique Photography. In case you have any event, consider working with Dawi Afrique Photography for them to actually document your event. Just to also give you an assurance is that if you missed part of the interview, the sweetness with this broadcast is that we shall not be removing it at the end of this particular broadcast. So if you have a friend who may not be watching necessarily right now, send them the link. The link will remain valid even later after this particular broadcast, and they can be able to watch it. We also promised you to do smaller cuts for the purpose of enabling you to share more with your friends. As we continue, Dr. You've talked about scanning as a lack of scanning as one of the biggest risk factors. Maybe talk to us about scanning. How often should our women scan for cervical cancer?
Thank you, Bona MC, for that question. So not necessarily scanning, but screening. Basically, screening means selecting, or rather subjecting women to various modalities of, it could be either just visualization or taking a bit of samples from particular areas where you want to screen them for that particular cancer and kind of try to look for any early signs of disease, so that in case you see that, you subject these women now to other confirmatory tests for that particular suspected cancer. Once you've confirmed for that cancer, is then now you subject these women to treatment for those particular cancers. So it's not just cervical cancer that has screening, tests for detecting these cancers early, but other cancers, for example, breast cancer, which also affects women predominantly, you can do things such as mammograms or breast ultrasounds early enough. There are things such as self-breast examination, so that you detect the most minimal or the smallest of breast changes that could signify early breast cancer. So that's for breast cancer. For cervical cancer, we do screening, and the people who are eligible for screening for cervical cancer, and this is very important for all women to realize, because like we said, one of the highest risk factors for cervical cancer is the fact that our women, a good number of them, are not really going for screening, and they do come to us once they've already had signs and symptoms for cervical cancer, which most of the times is quite at an advanced stage of the disease, in which survival for these patients, even with treatment, is not as good as when you diagnose them earlier on during the disease. So maybe to put in perspective before I move to screening is, we talk of how cervical cancer progresses. We talked of it takes roughly between 15 to 20 years from the time someone is exposed to the time they get invasive disease, that is invasive cervical cancer. Now, before you get to invasive cervical cancer, there is the pre-invasive stage, whereby you might have some few changes that signify that you might be having a disease that might be headed towards cancer, but it's not really invasive, and it means that you can easily be treated and totally cured, which is why we need to reiterate that cervical cancer is preventable disease. We should not have our women being diagnosed with the disease. More so, we should not have our women dying from the disease. So besides the pre-invasive stage, which we target getting our women in that stage through screening, we also have the invasive stage of the disease, where we have the early stage of the disease and also the late stage of the disease. We shall look at the various treatment for these various stages later on, but I wish to get back to now the screening. Now the screening is normally meant to identify the women who are in this pre-invasive disease, whereby if you're just to go for a test and the gynecologists look at your cervix through an instrument known as a speculum, they might not necessarily be able to visualize anything, or rather a significant change in terms of how the normal cervix will appear, but they will do some sampling, and there are various techniques of screening that we normally do. So there is 3 modalities. The ones that are most commonly used in our population, that is in our country, Kenya, which unfortunately is not necessarily the best, but we've kind of stuck to that one because of the resources that we have. Number 1 is what is known as a visual inspection under acetic acid, and this is basically when you go to see a healthcare provider, and screening is not just done with gynecologists. Nurses are very good at this. Other cadres of medical professionals who are trained to do the screening are very much good at this. So like I said, there's the VI, the visual inspection under acetic acid, where you will be, the instrument known as a speculum will be inserted in your private area so that we visualize the cervix, and then they apply something there that is known as acetic acid, and they visualize any changes that might be seen after application of this material, which we normally view after a minute or 2 of application of that material. Then will signify then probably this patient has early stages of, or rather has pre-invasive cervical cancer, and probably needs to be subjected through other diagnostic modalities. So just this screening is not enough to tell us that you or you do not have cancer. It just gives or heightens our suspicion of whether or not you might be having it, so that we send you now for a confirmatory test to see whether indeed you do have cervical cancer. Besides the VI that I talked about pertaining to screening, there is also the pap smears that are very common, that I'm sure most of our women are aware of. So they just take cells from the cervix and from within the cervical canal, and they send them for evaluation under a microscope, so that we look at cellular changes that might signify that the patient might indeed have early changes or pre-invasive signs of cervical cancer. Last but not least, and unfortunately, in as much as this is the most, efficient method of, picking up or screening cervical cancer, which is the most used in Western world, in the UK, in the US, in most developed countries, it's what is known as HPV DNA. Remember, we talked about HPV virus being responsible for 95% of cervical cancer. So if we are to pick this DNA material of this virus, then it almost signifies that these women might be having cervical cancer. Now, when it comes to HPV virus, there are several types that are responsible for various diseases, including cervical cancers. There is the high-risk types that are mostly responsible for these cervical cancers, including HPV virus type 16, 18, and then, of course, 16 and 18 are responsible, for example, for 70% of cervical cancers. And then we have other types, for example, type 31, 33, 45, 52, 58 types. These 5 types of the HPV virus are responsible for the remaining 20% of cervical cancer cases. So these are some of the few viruses that we normally test for that would signify that this patient is very likely to be having HPV virus infection around their cervix, and most likely also at a higher risk of being diagnosed with pre-invasive stage or rather disease of, or rather pre-invasive cervical cancer. So this is the screening methods that we have. The ones that are most commonly available in our public institutions, the ones that we use the most, unfortunately, it might not necessarily be the best, but they're still quite useful. That is the VI that I talked about. The first one, VI, and the pap smears. Although pap smears are also not commonly seen in public hospitals, you'll find them mostly in privates. And then lastly but not least, with the advent of private health practice and whatnot, the HPV DNA are commonly available in private facilities at a cost, unfortunately. They are quite expensive, might run you anywhere between 5,000 to 7,000 to test those ones. Fortunately, there have been programs by the government in conjunction with some NGOs that have kind of tried to bring about this screening using the HPV DNA, as the most efficacious way of screening for pre-invasive disease, that is cervical cancer. So who do we get to screen? Basically, who is eligible for screening for cervical cancer? Anyone who's been sexually active before, number one. Number two, the target population as per the new WHO, that is the World Health Organization guidelines, should be anywhere between 25 to 30 years onwards. So women who are 25 to 30 years should have at least started screening for cervical cancer, particularly using the primary method of screening, that is the HPV DNA. Using the not necessarily recent screening guidelines, we start as early as 21 years for women. So whether sexually active or not, it's good to start screening at 21 to 25 years. You actually need to start screening earlier. Remember, we talked about HIV as one of the risk factors. So when you're using the HPV DNA to screen women, for HIV patients, you start as early as 25 years. For those who are immunocompetent, that is, they have a functioning immune system. So for these ones, we start 30 years onwards. So not to confuse the viewers, if we are to stick to the relatively older guidelines, as early as 21 years is when we should start screening almost all our women almost all women are at a risk of getting cervical cancer. So we start screening at that particular age. The frequency of the screening is also very important because the different tests that I mentioned, the 3 screening types, we have the VI, the pap smears, and of course the most efficient one being the HPV DNA screening. So for HPV DNA, we normally do it every 5 to 10 years, mostly every 5 years. You've had your sample taken. If it comes back negative for the high-risk HPV types, then we normally tell you, if you are immunocompetent, that is, you are not HIV positive, your immune system is not affected greatly, then we normally advise you to come back for screening after 5 years. If you are a woman who happens to be living with HIV, then we normally advise you to come a bit earlier because your risk of getting cervical cancer is actually higher compared to someone who's not, whose immune system is not affected by a virus such as HIV. So for those ones, we normally tell them at least every 3 years of the HPV DNA test is warranted, okay? Now when it comes for the test that we most commonly use, that is the VI and the pap smears, for these ones we normally do also every 3 years for women who have, that is what are known as immunocompetent, that is their immune system is not compromised. But for HIV patients, we try to screen them annually. That is either for VI or pap smears. We try to do the cervical cancer screening every year for HIV patients or any woman who has some form of immune suppression, because it's not only HIV that causes that one. So for these ones, we screen them every year. Say, for example, if you've done your screening today, pap smear or VI, we advise you, and there are cards that we give you to bring back for the next session. We give you the next appointment so that we see you in, say, 3 years if you are HIV negative, or if you are immunosuppressed, then we see you annually so that we pick this disease before it starts showing signs. And the thing about cervical cancer is you are very much capable of detecting it at its pre-invasive stage before even you get the signs and symptoms of this disease, which I'm sure one AMC is going to ask me as the next question. So on to you.
He's going to ask you as the next question. For the first time, it seems you'll get it wrong. And nonetheless, it's because there is a question that has come in severally, and I thought of asking it. Funny enough, with Wednesdays, you usually realize that people prefer asking me questions inbox. So maybe I'll be sharing my inbox with you today.
Sure.
So there's somebody asking why many women are not actually willing to go for screening. Of course, one of them asking here is a man, that, and it's a long story, but then they are saying that they've tried with their sisters, mothers, and even the wife to send them for screening. If they go for the first one, probability of going to the second one comes down. What from where you sit as a doctor, what could be the reason why women are reluctant to go for scanning?
So there are a couple of challenges that might bring down our levels of screening in the country, and actually not just Kenya, most of the places. And I wouldn't necessarily blame it on people who are potentially victims of this disease or can be victims of this disease, that is women, to be precise. It could be systematic issues from the how we screen these women, the environments we screen these women. For example, if you go to a place where privacy is not really ensured, you go to a place where the people who are meant to be kind to you and counsel you about cervical cancer are kind of rude to you and not necessarily talking to you or handling you in a manner that is sensitive, then you might not be having the best of experiences for you to even be motivated to go for those services. And most of these services are actually offered for free in government hospitals, particularly when it comes to VI screening. Pap smears, they do come at a cost, although not as expensive as the HPV DNA screening. So those are some of the few systematic challenges. Of course, we also have the normal issues that we blame. I'm not talking about climate change and soil erosion, of course.
And lack of capital.
Exactly. So things that are normally to blame. So, for example, lack of, the necessary tools to do these specific screenings. For example, for cervical cancer screening, we need the speculums, we need the vinegar, or rather the acetic acid that we use. For pap smears, we need to have competent people to, the pathologists that normally look through these cellular changes, and even the sample collection material. So particularly in most county hospitals, rather a good number of the county hospitals, they might not be equipped with these ones unless they are very vigilant in equipping, our healthcare personnel with these equipment, and also, having well-wishers or NGOs that also do donate these equipment for screening. So those are some of the few systematic challenges. Of course, we have with the intrinsic challenges for the women themselves. There is the stigma associated with, or rather the cultural aspects of it, of having someone to check down there that is normally taken as, taboo for some. Some are a bit embarrassed. Some are a bit, scared what might be discovered there. Some of those things. But I guarantee our viewers that whatever stigmas, whatever preconceived notions about these, things that might actually be preventing them from going for screenings are not worth you coming later on, 10 years, 15 years down the line with cervical cancer symptoms at a point where there is basically very little that we can do for you besides probably sending you for radiotherapy and chemotherapy. So I really, really reiterate the importance of screening. Personally, the people I've worked with, from the nursing teams to our able clinical officers to fellow doctors and everyone else that I've personally worked with, seem to be very accommodating because we know the importance of screening. So you try to create a conducive environment where women who already have their own preconceived notions about the screening will actually feel comfortable enough to come to those services that we offer. Otherwise, we might have the services but people are refusing to come to us because of probably how we are handling them or how, they are handled at that particular area. So I think that's, from my experience, some of the few things that might lead to the challenges when it comes to screening of these women.
Okay, Dr. Issa Moshey with us in studio, helping us understand cervical cancer. My name is MC Kalia, and as we continue with this particular broadcast, of course, Daktari has been waiting for the question about warning signs of cervical cancer. But then also, before we go there, is there any form of maybe drugs that, not maybe vaccination or something like that towards cervical cancer, or are there any studies towards that direction at the moment, before we just come to also the warning signs for the cervical cancer?
Sure. So maybe I wouldn't just guide it towards vaccination per se, but I will take the topic towards prevention of cervical cancer. So when we talk of prevention of any disease or cancer, we talk of it at 3 different levels. There is what is known as primary prevention, there is the secondary prevention, and then there is the tertiary prevention. So when it comes to primary prevention, basically it's putting or rather employing mechanisms that will prevent the acquisition of risk factors for cervical cancer. And these include HPV. We talked of HPV as the most, or rather responsible for 95% of cervical cancer. So if you are to prevent people from getting exposed to this disease, or if they do get exposed, at least there is protection against that disease, then we now talk of primary prevention of cervical cancer. So what are some of the things that we can employ as primary prevention? Number one, and this is something that we have been singing over and over again, particularly for Kenya, it's not so an old thing. It's something that has been introduced in the recent past. So we talk of cervical cancer vaccination, HPV vaccine. So HPV vaccine is basically vaccinating vulnerable, or rather women, or rather people who are at a risk of a disease. And who is at a risk for cervical cancer? Of course, women. And when do we want to vaccinate them? We want to vaccinate them before they become sexually active. Remember, we say that HPV virus, or rather HPV, is acquired sexually. So you want to give them a vaccine that before they kind of initiate sexual debut, before they get sexually active. So the best time to give girls in particular this HPV vaccine as a form of primary prevention of cervical cancer is before they get sexually active. So we give them, and this is also a government initiative that has been going on, we vaccinate our girls from 9 to 14 years. We start giving them HPV vaccines, and normally we give, it used to be 2 doses, but studies have shown that as little as 1 doses is enough to prevent them. But then if you can get to 2 doses, and normally they're almost 6 months apart, they're given 6 months apart, you get the young girls vaccinated before they get sexually active, because in as much as we are trying to, the sexual debut age for the country is around 15, 16 years. So you want to get these young girls and boys, by the way. So vaccination is not just for girls, it's also for boys. But mostly we want to target the ones who are affected the most, that is young girls between the ages of 19 to 14. We vaccinate them, giving the HPV vaccines. Now there are several kinds of HPV vaccines, 3 in particular. There is one that covers or protects you. Remember, we talked about there are several types of HPV vaccines. We want to give you vaccines that protect you against the types that are most commonly responsible for cervical cancer. So we are talking of type 16 and 18, type 31, type 33. So the one type of the vaccine only covers against 2 types of the virus, type 16 and 18, which are responsible for about 70% of cervical cancers. And then there's another type that protects you against 4 types of the HPV viruses. Now remember, we talked about there's high risk HPV and there's low risk HPV. Now the high risk HPV is mostly commonly responsible for cervical cancer. However, there are low risk HPV that are not necessarily as responsible for cervical cancer, but they're responsible for other conditions. For example, things known as genital warts, the swellings that some women might get around the genital area, or even men can get genital warts. So this type of vaccine, the second type of vaccine I'm talking about, not only protects women against or men also, type 16 and 18 virus that causes cancer, it also protects against type 6 and 11, which are commonly responsible for the genital warts that we talk about as part of the disease complex of HPV. Of course, there is one that is also in the Kenyan market, although quite expensive. It protects against 9 types of the HPV viruses, including the ones that are protected from the 4 one. So this one that protects against the 4 virus types is known as the quadrivalent vaccine, known as Gardasil 4. The one that protects against the 9 types, that is the one that is most, it's quite expensive, but worth it in my opinion. It's called the Gardasil 9, a nanovalent vaccine. Basically, it means it protects against 9. So that's one of the ways of primary prevention of cervical cancer. Now, I need to reiterate that in as much as we are talking about administration of these vaccines in girls, young girls and boys if possible, between the ages of 9 to 14 years, women who are, or the young girls who are 15 years and above can still be vaccinated. In fact, the HPV vaccine can still be administered to women as old as 40 years. So it's not just to say that I've already been sexually active, I've already been exposed to the HPV virus, can I still get the HPV vaccine? Of course. So you can actually still get the vaccine because you can never know what type of the viruses you have been exposed to. Remember, we talked of various types, so you might have been exposed to a certain type, so you can still get a vaccine that reduces now, or rather
risk of getting
the other type that you might not necessarily have acquired, despite the fact that you've already been sexually active. So it's quite important that we reiterate this fact that just because you're past that age that the government has told you to go for the vaccine, doesn't mean that you do not qualify to get the vaccine. Unfortunately, you'll have to pay for that because the one that the government is giving for free is for young girls between 9 to 14. But if you are interested in getting the vaccine and you are beyond this age, then you can meet the cost of that vaccine. The other thing about vaccines is just because you've gotten a vaccine doesn't mean you stop screening for the cancer, because in as much as we are it's the same way like you've gotten the vaccine for COVID, it doesn't mean you are 100% protected. You can still get cervical cancer. So for women who've gotten the vaccine, you still continue with your scheduled screening for the cancer. So that's important to note. For HIV women, we normally, like I said, we normally give a minimum of 1 to 2 doses of the vaccine. For HIV women, HIV positive women, we normally try to give at least 3 doses so that we improve the protection in these women. So that's it in terms of the vaccination as a form of primary prevention of the virus, or rather of the cancer, of cervical cancer, sorry. The other primary prevention methods include preventive methods. Remember we talked of the high risk. So being faithful to your partners, that's some form of primary prevention. Wearing condoms, basically avoiding unprotected sexual intercourse. The other things include, there is also been studies that have proven that men who are circumcised have a lower risk of, carrying that virus and possibly transmitting it to their female partners. So that's also another thing that has been attributed as a form of primary prevention. And of course, screening, they go there. So these are the forms of primary prevention. So secondary prevention, of course, screening falls under secondary prevention, so that if you pick, pre-invasive disease, that is signs that this lady or this woman is about to have invasive cancer, that is, she has signs that she has pre-invasive signs. So this is a form of secondary prevention, because you've gotten the disease at a very early stage that can be totally cured, so that once you've picked these women with pre-invasive disease, you can send them for treatment of this pre-invasive disease, which has almost 100% cure rates, okay? And then, of course, the tertiary prevention of cervical cancer now involves those women who now already have the cancer, but you want to get it at an early stage, so which means you do various tests for these women and direct them to the various treatment modalities. So these are the ways that we have, or rather the different ways we have of preventing cervical cancer in women. Yeah.
Okay, thank you so much for that. Of course, you'd wish that every woman listens to this, and that is the reason why I'm telling you, you can share this particular broadcast so that it is able to help more than just those who may be subscribed to us. I can see Kosgei Rapches here saying he's tuned in all the way from Kisii County. Chiri K saying tuned in from Biafrik. Good topic indeed. Alicia Chebet says tuned in from Cabernet. Thank you so much for making time to be with us. MCRK all the way from Eldoret says good morning to you. Edwin Kim Sanai says nice topic for the day. Happy International Women's Day, and let's not forget our healthcare professionals who are working all through the globe to save lives. Judith Chepkoech Yegon says tuned in. There's a few comments that came in a little bit early. Mildred, some good morning, team morning glory. Liz Rokesio says good topic. Rahma F. Bawazir says a great topic. Happy International Women's Day. Thank you so much for making time to be with us. Geoffrey Kevolwe says tuned in. Thank you so much. And of course, if you're joining us for the first time, remember to click the notification button so that the next time we go live, you are able to actually watch the other guests in the Morning Glory Show. Of course, as usual, I shall tell you that what we do here is to make sure that you live an edified life. One of the biggest challenges we'll always face is time, but then we try to make sure that within the short time we get, we discuss as many topics as possible. Remember, this particular show today is brought to you by Top Hill Hospital. Top Hill Hospital is situated in Elgonview. It is a level 5 hospital, dealing more with brain and spine complications, but then remember, they have all the other clinical departments, and so you can always visit Top Hill Hospital for all your health needs. It is located at a very serene environment, easy to access. I told you almost every way within Eldoret town leads to Top Hill Hospital. If you're coming from Nairobi, there is just immediately after Poor Place on your left, there's a road there. I think within Eldoret town, there are almost any route that goes into Elgonview will lead you to Top Hill Hospital. If you find it hard locating or getting the name Top Hill Hospital, it is just adjacent to Boma Inn, actually. Yeah. So anytime you need to any kind of medical attention, consider walking into Top Hill Hospital. Somebody the other day told me not everyone walks into hospital, so make your way to the hospital anyway. So with us today is Dr. Issa Moshey, helping us understand cervical cancer. And there's a question that he's actually been waiting for so much: the warning signs. What are some of these signs and symptoms of somebody now who is who has contracted or is on their way to contracting a cervical cancer?
Thank you, Bona MC, for that. And thank you to the viewers who've tuned in and the questions that have been coming in, or rather the questions and the comments that have been coming in. So, like I said, at the initial stages of this program is the fact that we are really trying to get our women before they actually get to the stage of invasive cervical cancer disease, that is. Remember, like I said, it takes roughly 15 to 20 years before you even start getting invasive disease from the exposure to the virus, that is the HPV virus. So the whole essence of doing screening is so that we get or we catch our women before they even start showing signs, because by the time a woman comes to you with what I'm about to list as some of the signs for cervical cancer, it might be a bit advanced. And you know, the prognosis, that is the how we say a patient has chances of, you know, responding to treatment and probably survival, worsens with the stage of the disease. So we really want to emphasize and reiterate to our women that you really want to go for screening before you start developing symptoms, because it might take you years before you even start seeing symptoms, signs and symptoms. And by the time those develop, these there are things that we can do, but they are not as good as when we discover you before you even start showing signs. So what are these signs and symptoms? And mostly these are signs and symptoms of invasive disease, not the pre-invasive stage which we normally get during screening. So the invasive stage, you'll find early disease signs, such as someone just comes to you with you know how normal periods will be, that is menstrual period. So someone all of a sudden starts reporting abnormal periods, in the sense that it's quite heavy. Sometimes it could be, you know, in between their periods, that is, they've had their period a week or 2 weeks ago, and then in between they get some what is known as intramenstrual bleeding, that they got a bit of spotting, or sometimes it could be even some form of light bleeding that is not really usual of their menstrual pattern. So that's one of the signs of particularly invasive disease. You can have certain things such as discharge, that you know, from the private parts. You can have discharge from that area that doesn't really look like it's something could be normal, because there are some certain types of discharges from down there that might be normal, or it could just be due to some infections, including candida, including some of the sexually transmitted diseases can also form certain discharge. There are also a bit of discharges, some few discharges that can actually be normal, due to normal body functions of the female genitalia. However, for cervical cancer, it could be not necessarily specific. It could be just discharge that is brownish, a bit reddish in color, mixed with blood, a bit not very pleasant in smell. So that's that's one of the signs that you can get. Of course, as the disease advances and it starts, spreading to, adjacent organs or organs that are close to the cervix and the uterus, you might get someone complaining of vague abdominal pains, lower of the lower region in particular, back pains. They might complain of, lower limb swelling. So they say mguu imefura, like one of the leg or both of the legs are swollen because of that, infiltration of the vessels that drain the lymphatics or blood supply of that area. You can talk of signs of distant spread of the disease. For example, remember we talked of advanced stages of the disease where blood, or rather the cancer has spread to the lungs, it has spread to the liver, it has spread to the bones. Now you start experiencing women with cough because of disease spread to the lungs, liver, where you have like the eyes become yellow, they are jaundiced in medical terms. Some of those who've had brain spreadings, that is metastasis, can even have convulsions because the disease is now involving the brain in advanced stages of this disease, particularly what is known as stage 4. The last stage of the disease. So as you can see, some of these signs and symptoms are not very specific to cervical cancer, because there are a couple of other conditions that can present themselves in this manner of ways. For example, there are women who might be tuned in and listening to this and they are like, oh, could I be having cervical cancer? The best way to know that is you just go for screening and testing if needed, diagnostic testing that is. So you cannot just use this and say, I do not have these ones, so I do not have cervical cancer or pre-invasive disease, or you cannot just have what I've mentioned to you and you categorically say that, oh, I think I have cervical cancer. The best way to go about this is go see a trained healthcare practitioner, healthcare worker to do the screening so that they rule out. And if they do the screening and they see signs of, pre-invasive disease, that means it's a disease that is not yet invading your or the stages that we've talked about that we try to worry about, then they will now send you for what are known as confirmatory tests that can actually categorically say you do indeed have cancer or not, and then we direct treatment towards that direction. So those are some of the few signs and symptoms that we can have.
Of course, I'm just trying to read a very long comment here. Maybe I will be able to capture that at the end of the broadcast if time allows us, or I'll just forward the message to Daktari. It's quite a long story of what somebody has been through. Of course, I know somebody is watching the broadcast keenly, but then I would prefer maybe to just forward that to you later. Then you may be able to see the doctor later. Anyway, just to stick to today's topic, Daktari, you've talked about the warning signs. Of course, you realize that I intentionally wanted us to spend more time in prevention because once we get here, things may not necessarily be so good. Now, let's assume and let's imagine that somebody has actually shown the signs. You've gone ahead and tested, and there is proof that actually they've contracted cervical cancer. Let's talk about treatment and successes.
So another good question. I think you should have been a medic. Yeah, these questions are very, I know the target audience is not necessarily medical professionals or practitioners, but it's a very good way of channeling the questions and directing them towards the necessary areas that need to be talked about. So kudos to that one, IMC. You've done your homework. So what are the treatment modalities? So the treatment, like I said, remember when I talked about the various stages of the disease. So you have, first and foremost, we try to catch the disease in its pre-invasive, that is before it invades the cervix and goes deeper to, become now invasive disease. So so there is the pre-invasive, and then there is the invasive. And invasive in itself is also divided into two. There is the early stage invasive disease, and there is the late stage or advanced stage invasive disease. So treatment is just targeted towards the different stages of this disease. So for pre-invasive disease, most of the times, once you've had your screening, your pap smear, your VI, or even your HPV DNA for those who've gone for those, so if they show signs that they might be having pre-invasive disease, they are normally sent for another test, normally a biopsy. I don't wish to get to the details of some other modalities known as colposcopy and whatnot, but ultimately you just need a biopsy, basically a tissue, a small portion of the areas in your cervix that are showing signs that it might really be at pre-invasive stage of the disease. We normally take a sample from that area. Once it's confirmed that it's actually cervical cancer, for the pre-invasive disease, there are also various stages, what is known as CIN1, CIN2, CIN3 of this disease. So for CIN1, sometimes even with signs of pre-invasive disease, it doesn't necessarily mean that you get to be treated. There is a role for follow-up, because remember we talked about 90% of women who've been exposed to HPV do clear the virus naturally, especially for those who have a functioning immune system. However, for the pre-invasive disease, that is, we have the CIN2 and CIN3, normally we wish to have these women to actually get treated for that early, or rather that pre-invasive disease, because pre-invasive, advanced stages of pre-invasive disease are more likely to advance into invasive disease, and which is why we advocate for these women to get treated. So what are the treatment modalities for these ones? Normally they are various. They are what are known as thermoablative treatment modalities, where we kind of burn through that cervical area where the cervical cancer will normally start from, so that we kind of remove it before it goes into invading the cervix. So those are some of the ways. There are other ways known as cryotherapy, and last but not least, what is known as a LEEP, that is LEEP, that is loop electrosurgical excision procedure. So all these modalities, fortunately, or rather a good number of them, are available in most government institutions, in conjunction with the county governments, and also some NGOs that have been donating some of these machines that we use to perform these procedures for these pre-invasive disease. So that's just a breakdown of what we normally do for those women who we detect to have cervical, or rather pre-invasive disease, that is cervical cancer, before it becomes invasive, through screening. So for these women, we can treat them, and the cure rates are 100%. But we normally want to have them coming back for regular screening after we've done the treatments using these modalities. Now when it comes to invasive disease, remember I talked of early invasive and advanced invasive disease. So the treatment also depends on where this patient is. For cervical cancer, we have 4 stages. We have stage 1, stage 2, stage 3, stage 4. Normally, we try to, unfortunately for most of the women who come to us, they come to us with symptoms. And if someone comes to you with symptoms, it's quite likely that they are no longer in the pre-invasive disease. So they will come to us stage 2, stage 3 of the disease. And they've later the stage, or they are more advanced the stage a woman presents in, the less likely, or rather the lower the prognosis. And by prognosis, I mean their chances of getting higher cure rates and their chances of survival after being treated are slightly lower with advanced stages. So if someone comes to us bleeding, discharge, vaginal discharge, and then you kind of test and you already see a mass there, then it's quite likely that is advanced disease. That means that they are beyond that early stage disease. And with early stage disease, there is a role for surgery. So besides surgery, there are certain things that we can do, things known as conization. Around there, I don't wish to get to the details of these, being that my target audience right now is not necessarily medics, but there are ways that we can do some procedures that are not necessarily, particularly, remember I talked of cervical cancer to be involving women who might still be in their reproductive age groups, they wish to get children. So if it's very early, we might do some procedures there that might preserve their uteruses so that they can get pregnant later on. Okay, so
actually you've just mentioned that right at the time when somebody is asking, once I get cervical cancer, can I still have babies? So actually go ahead and just
it will depend on what stage. So for example, if it's advanced stages of the disease, most likely we might end up doing, I'm about to get to the treatment in these stages, so maybe if I go through the treatment stages. So remember I talked of 4 stages of cervical cancer. So for stage 1, it's also broken down into various small groups that I don't wish to get into. However, the treatment is directed towards these stages, and various things that we normally detect in these women will detect to us what more needs to be done in these women. So mostly we do fertility preserving procedures in these women, especially in those who are very early stage disease. Unfortunately, most of our women do not come in that stage. So for these ones, you can just do what is known as conization. Some of them even qualify for that LEAP that we do in pre-invasive disease. And then, of course, then we move towards now doing hysterectomies. And these hysterectomies that we normally do are not the normal hysterectomies, that is removal of the uterus and the cervix, that we normally do in women with, you know, say, for example, fibroids or other conditions that cause them to bleed. Unfortunately, a good number of women will need what is known as radical hysterectomy, and this is an advanced form of hysterectomy that might not necessarily be done by your typical or your general gynecologist, might actually need to be done by what is known as a gynecologic oncologist, which brings me to the point that it's quite important that you are very much aware of who's treating you, because quite a number of us, in as much as we go by the term gynecologist, might not necessarily be qualified enough to be performing some of these surgeries, and we need to be referring you to the right specialist. That is, they are indeed gynecologists, but trained to deal with oncologies, that is cancers that pertain to the gynecological area. So those are some of the few things that we do. So even in early stage, there is a role for fertility preserving procedures that we do not remove your uterus, we remove a portion of your cervix. Sometimes we can even remove the entire of the cervix and leave your uterus, so that there are ways that you can still get pregnant. But it depends on what stage of that disease. Because you cannot demand for a treatment, or rather request for a treatment for advanced stages where you actually need to have your entire uterus removed, but you have it retained for the sake of you getting pregnant in the future. That means you are risking for recurrence of the disease. So you will be advised accordingly after staging of that disease appropriately, which is the best option of treatment. Now after the early stage disease, unfortunately, you lose the window of surgery, because if you come beyond what is known as stage 1B, 2, remember, even those stages, 1 is divided into 1A1, 1A2, 1B1, 1B2, 1B3, so I don't wish to get into that, but just so to speak that as early as stage 1B2, once a patient gets to stage 1B3, now it becomes what is known as surgically non-amenable. Basically, you cannot be treated with surgery. These are the patients as early as stage 1. I need to reiterate, the advanced stages of stage 1 cannot have surgeries, unfortunately. Most of these patients will benefit from what is known as chemoradiation. That is, you go through the radiotherapy and chemotherapy in conjunction. And of course, the prognosis for this also depends on what stage, but it's not as good as someone who's had treatment in the early stages of cancer. So just to summarize, you can be treated in ways that will preserve your uterus. You can get pregnant in the future. You can be treated in ways that the whole of the uterus and the cervix plus a bunch of other organs around are removed, or other adjacent tissues from around are removed. And last but not least, and unfortunately this is what most of our women go through, because they come in advanced stages of the disease where you cannot have surgery, you go for chemo, that is chemotherapy and radiotherapy. And remember, with chemotherapy and radiotherapy, these are drugs that also affect your fertility. So once, if you are in that stage and you get treated and you kind of go into remission, you can your chances of fertility have also been brought down, because you've been exposed to drugs that affect your ovaries and how you produce the follicles that will eventually go into getting fertilized to produce a baby. So fertility is reduced in a tremendous amount, even in women who've gone through chemoradiation. This is also to answer the question of the viewer who's asked about fertility issue or whether or not they can get pregnant. So it all depends on the stage and what kind of treatment they were given. Otherwise, we've had patients who've gotten pregnant after, getting treated, particularly those from early stages of the disease. Yeah.
Okay, thank you so much for that. And of course, you'd notice, and I'll repeat this, that I do not want us to talk much about the issue of treatment, because it may not be in our hands. Let's actually focus more on the prevention part of it, the screenings and all that. And of course, if you're already tuned in, this is the Morning Glory Show. It is the most comprehensive talk show in Kenya today. I usually love saying that the most important conversations happen on the Morning Glory Show. You don't want your relatives and friends to miss this, so please do share the broadcast. And of course, Daktari can confirm this, that at Dawi Afrique Photography, you get a nice experience in front of the camera. So in case you need a nice experience in front of the cameras and nice memories also well documented for you, consider coming to Dawi Afrique Photography. Book us for those events, and we will assure you of well documented memories. Now, Daktari, as we come to the tail part of this particular interview, there's something you mentioned when you were talking about prevention. Of course, we talked about screenings. When we talk, I would love us to talk about insurances a little bit, and how willing they are to cover this particular menace. And let's talk about it in also prevention stage in terms of screenings and all that. You've talked about the better technology being available majorly and mostly in private institutions. How willing are insurances then to cover such screenings? Then also maybe touch a little bit also on treatment.
Okay. So maybe I wouldn't go into details about the insurance part of it, because a good number of them, or rather most of them, are quite different from one another, that is. So there are some insurances that can cover, say for example, contraceptives is a very sensitive topic. Some insurances might pay for it, some will not. When it comes to vaccines of any form, some insurances do cover those ones, others do not. So I cannot blanketly speak in a way that will be representative of all the insurances that are out there. So that's probably something that if a viewer, one of the viewers, has a query with the insurances, this is best taken up with that particular insurance so that they discuss with that. Now, in terms of government agency in the vaccines and whatnot, like I told you, or like I made it clear, is that there are free vaccines that are given to girls between the ages of 9 to 14 that have been ongoing. I think they even had the campaigns at schools, public schools, all schools in particular. There were also a debate and controversy going on around the topic, but fortunately the uptake has been good. It can get better, but I'm proud of the advances we've had. In terms of treatment, I would actually advise our viewers, not just the women, but even the men tuned in, please register for the bare minimum, at least NHIF, because you don't want to register when you've already gotten something. And the mistake most of our patients do make is you'll find someone already comes to you, they've been diagnosed with cervical cancer, is when now they wish to get the insurance, because treatment for cervical cancer is expensive. Especially the women who come to us are women who are going to get chemotherapy and radiotherapy. They are not the surgical stage ones. And chemotherapy sessions, you go through several radiotherapy and chemotherapy sessions, and they are quite expensive, and they could go to the tune of hundreds of thousands, the entire treatment. And then of course there is the tests that we do, there is the imaging that we do in these women. So the bare minimum, you do not wait to get not just cervical cancer, any disease that might see you at the bad end of this spectrum that is admitted at a hospital requiring treatment, at least have NHIF, because NHIF pays for all of the treatment, especially when you go to Moshey Teaching and Referral Hospital. If by the unfortunate aspect that you've been diagnosed with cervical cancer and you need radiotherapy and chemotherapy, NHIF will pay for all of this, together with the imaging and everything else. Even private hospitals, they do have agreements with NHIF that they get paid with that. Maybe some of them you have to top up on top of what NHIF is paying, but at least a good portion of it would have been paid via NHIF. So that's something that I really, really wish to reiterate to our viewers, that have some form of health insurance pertaining bare minimum being NHIF, and of course if you can afford the private ones, you can also go for those ones. Now in terms of I don't know if I'm in a position to summarize the talk, is the WHO, that is the World Health Organization, came up with a sort of like a policy back in 2018 to bring about the cases of cervical cancer in the globe. And they have a vision, the same way we have Vision 2030. So WHO has a vision that brings about, so it's called the 90-70-90 vision for 2030, whereby it aims for almost all the nations in the world to have at least, number one, 90% of girls before the age of 15 to have been fully vaccinated with HPV vaccine by 2030. Sadly, we are nowhere near that one, and we are approaching 2030, probably in the next 7 years, that is. So that is one of the visions. Number two, in terms of fighting the menace that is cervical cancer, the 70, that is, 70% of women, particularly those who are between the eligible candidates. But so at least 70% of women should have at least one high-performing test of screening having been done by 35 years, and at least two by 45 years. So this is
still far away
minimum.
from that.
Still very far away. The screening, and by primary or rather high or rather sensitive tests, we talked about its HPV. So we are nowhere near that one, but we are headed towards that direction due to different policies and, in conjunction with the government, and even what Top Hill is doing right now in conjunction with you, that creating that awareness is very important so that we reach this level. Because I've seen several patients who come to us, even we talked about this cancer being mostly common in women between 35 to 49 years, but I've had women 60 years of age, she's entered menopause, she's no longer having periods, and then all of a sudden she comes to us with bleeding in the postmenopausal period, that is after menopause, and we kind of also do suspect cervical cancer as one of the things that can cause that. So, in as much as we are talking of screening increasing, but sadly we have such women who come to us, 55-year-olds, 60-year-olds, never had cervical cancer screening done their entire lives. And that is the first time when we meet them that we try to kind of see if we can do screening, or most of the times they come already with things that are visible there that are now beyond screening. Now you just need to do a biopsy. So the second rule, 70% of women should have at least by 35 years of age have been screened, by 45 at least twice. So that's number two. Number three, at least 90%. Remember you talked of 90, 70, 90. So number three is 90% of the women who have now been diagnosed with cervical cancer should at least have access to treatment, be it, the surgeries or the radiotherapy and chemotherapy. So that is the target. These are the ways that the WHO has initiated, the targets that we need to, achieve by 2030 to curb this menace that is cervical cancer. Take-home message to our women is please, please spread the gospel of screening. And before screening, take the young girls and boys, if you can, to get vaccinated. 9 to 14 years, best time to get the screening, but beyond that, it doesn't mean you cannot get the vaccine. So start with that. Vaccination, screening, and at the same time presenting with any symptoms that sound familiar to what I've actually described right now. But the best option, vaccines, screening, and then treatment for disease in its early stage. So this is the take-home message for today.
Okay, thank you so much for that. I know you should be switching off your mic, but then people asking me severally if you're free to give your contact, so that will actually depend on you. If you're free to give it, then I'll actually also pin it on the comment section. Yeah.
So maybe not my private contacts, but I'm here on behalf of Top Hill Hospital. That's where I practice. We are a number of us there, that is pertaining to the gynecology and obstetrics department. So we don't just look at matters cervical cancer, of course, all gynecological issues, pregnancy related, just following up of normal pregnancies. You can find us at Top Hill Hospital, that is next to the Boma Inn in Eldoret. And most of these services that I've actually mentioned, from the screening to the treatment, can be found at Top Hill Hospital. But in case, and this is not to, make it, a matter of those who can afford. For those who can not afford private practices, please do not feel marginalized to go to places where you can be taken care of, including Moshey Teaching and Referral Hospital. It's a very good place that you can get screened for cervical cancer. At the Chandaria Chronic Disease Illnesses, that is center at MTRH, we do screenings also over there. Treatment also, we have a very good gynecologic oncology department. Both at Top Hill, we have gynecologic oncologists that do, consultations over there. You can also find them at Moshey Teaching and Referral Hospital for those of you who cannot necessarily afford private practices. So I'm trying to be inclusive of all people and not just those ones who are, capable of affording private healthcare. So find us at Top Hill. We are qualified group of obstetricians and gynecologists for all matters reproductive health, including cervical cancer screening, diagnosis, and treatment. You can find us over there. There is Dr. Moshey. You can find Dr. Lee. You can find some of our senior gynecologic oncologists, Dr. Isura, Dr. Tonui. They also operate from there. So feel free to come and join us at Top Hill for those services.
Okay.
So in case you need to reach to me, I wouldn't recommend personal contacts, but you can find us at Top Hill at any time. Thank you.
Okay, thank you so much for that. And it is, I think, 9 a.m. on the dot. And so from me, on behalf of all those who made effort, Mildred and Kim and others, to make sure that this broadcast goes on air, I thank you so much for making time to be with us. This is the Morning Glory Show. It is the most comprehensive talk show in Kenya today. My name is MC Kalia. See you tomorrow.
Karibu Top Hill Hospital, a brain and spine specialty hospital dedicated to providing extraordinary care through competent doctors and other medical personnel from premium institutes with knowledge on the latest and exceptional medical technologies.